right, hello everyone. So imagine Mr. Jones and his loved ones sitting in the doctor's office, trying to decide whether or not to have another 6 rounds of chemotherapy for his cancer, or whether or not to get an elective spine surgery for his lower back pain. Medical decisions are difficult, right? Many of us have been there. These decisions are hard because oftentimes they are so uncertain. Imagine that you're presented with information like this. According to the newest clinical trial, the procedure works 80% of the time in an average patient. You may be asking, wait, who is the so-called average patient? What if I don't look like that, right? Maybe I have hypertension, I have a smoking history, and there's radiating pain down my left leg. I want to know specifically if this procedure will work for me. These decisions are uncertain not only for patients, they are uncertain for clinicians too. What if my symptoms are a bit different from what the clinician has seen in the past in other cases? And there are sometimes so many treatment choices, right? What if there is a specific medication that would be more effective in my situation, but the clinician is just not familiar with? And when it comes to factors that affect health outcomes, sometimes there are many things to consider. You can imagine that there is a significant cognitive burden for the clinicians, right? How can we make sure that this really is the right decision for you? And getting it right is so important because medical decisions can have detrimental consequences. But wait a minute, right? I can't be the first one making these decisions. Someone else must have made these decisions before. What if we can harness what other clinicians and other patients have experienced and learned in the past? Put all that wisdom together, right? All the details and symptoms about all the patients out there, and use that information to help me decide what should be best for me. Not best for that mysterious average patient, but somebody like me. And this is the idea that motivated the development of medical decision support tools. The thought is, okay, if we gather enough data from people with a similar condition, so let's say low back pain, and record all the factors that may affect this outcome, maybe symptoms, or blood pressure, right, or age, as well as the outcomes that you're most interested in, which is no more back pain after spine surgery, then we can start seeing patterns that we have never seen before, right? We can start seeing that some of these factors may be more important than the others. We can express these relationships between the factors and the outcomes through mathematical formulas. And these formulas, which summarize information from many, many patients, can help me predict my chance of having this outcome. So these medical decision tools come in many forms, right? Here you can see an example of a decision tool for breast cancer patients who are trying to decide on treatment options. This tool is available in the UK on the UK National Health Service website. And as you can see, it asks patients questions like, what is your age? Are you postmenopausal? As well as a list of other information about the cancer itself, like tumor size, tumor grade. And once the patient enters all this information, it will calculate the chance of survival for each treatment option. It may show information like this. So for patients with these characteristics that you just enter, if they only have surgery, there's a 62% chance of survival. With hormone therapy, the chance of survival is increased to 72%. So information like this can facilitate that discussion between clinicians and patients about how to tailor the treatment plan for each patient. The clinician and patients can be more informed about the risks as well as the benefits of each treatment option. And this idea is not new. Over the last 50 years, many tools have been introduced. There are now tools that predict cardiovascular risks, cardiovascular disease risk, right? There are tools for surgical risks. There are tools that would predict your bone fracture risk, risks of a urinary tract infection. And in this cancer space, there are also many tools like this pancreas cancer survival calculator. And over time, these tools have become more and more sophisticated. They're leveraging on bigger data sets. We're now in the era of big data, right? We now have data on entire genetic information, with social media data, data from your smartphone, from your smartwatches, lots of data points. We also have fancier methods. You might have heard of artificial intelligence, right? Machine learning, and then the new kid on the block, generative AI. So this bigger data sets and fancier methods are all promising to help clinicians, patients, as well as their family make these very complex clinical decisions, and also to improve the consistency in medical decision-making across clinics, across the nation, and maybe even across countries. Well then, what can go wrong? So with all the rises in technological development, there's also the increase in concern that tools like this may exacerbate health disparities. So in recent years, it was brought to the medical community's attention that race is being included as a decision factor in many of these decision tools. What's the problem with that? There are worries that doing so would promote racial profiling, would generate patient distrust, would erroneously suggest that race, which is a social construct, has biological effects, and contribute to what is often referred to as race-based medicine, right? Providing different treatments for different groups of people based on the color of their skin. Well then, you may be thinking, the solution is obvious. We should just remove race from all the decision tools. Problem solved, right? Well, in fact, these concerns have led to calls from major health systems and institutions to revise existing clinical tools to remove race as a decision factor. So is the problem solved? Well, it turns out that the solution is not that simple. Race was included in many of these tools because it is actually predictive of the outcome, and often for reasons we cannot quite capture in our medical data. So when we simply remove race as a decision factor, we may end up with a decision tool that is less accurate. And even worse, it is less accurate among patients of color. And this is exactly what our research teams found in our study. In our study, we look at a colorectal cancer decision tool that was developed to help patients who have already received curative treatment for their cancer to estimate whether their cancer will come back. So this tool, available here on the MD Anderson Cancer Center website, asks patients to put a list of risk factors that would then predict their risk of their cancer coming back. The tool will then provide patients with a risk score, and if their risk score is low, they don't need to come back as often for monitoring. But if their risk is high, they will be recommended for intensive monitoring. So as you can see highlighted in that orange box over there, right, race was included as one of the predictors. So we used this tool as our case study to study what is the impact if we remove race from a tool like this, and especially how would that affect the accuracy of the predictions for people of color. So to look at the results, we plotted the predicted risk that is generated from this decision tool on the horizontal axis, and then compared that with the actual risk of patients coming back, of cancer coming back on the vertical axis. So you can imagine a perfect prediction is when the predicted risk match perfectly with the actual risk, when all the dots fall on that 45-degree angle line. And if any dot falls above that 45-degree angle line, it would mean that the decision tool is underestimating the actual risk. And any dots that fall below would indicate that this decision tool is constantly overestimating the actual risk. So let's see what we found. When race was included in the tool, we see that the predictions fall really nicely on that 45-degree angle line, suggesting that the accuracy for non-Hispanic white patients is actually quite good. We see a similar trend among Black patients. All the dots are falling on that 45-degree angle line. Now, what if we remove race from the tool? We start seeing that the dots are starting to deviate from that 45-degree angle line, right? Especially for the Black patients. This tool keeps underestimating the risk for the Black patients. So in other words, the tool became less accurate for racial and ethnic minority groups when we removed race from it. Okay, so let me summarize this. We want to remove race from a decision tool because we want the tool to be more fair for the patients of color. But when we remove race from the tool, we end up with a tool that is less accurate for people of color. And a less accurate tool would mean that we may be telling patients to come into the clinic when they don't need to, or even worse, we might be telling them not to come into the clinic when they are actually high risk. And this pattern that we've found have been confirmed by other recent studies as well. Researchers showed that when race was removed from a urinary tract infection risk calculator, more Black children would end up having unnecessary catheterization, a procedure that not only can cause discomfort, stress, and potential adverse events, but will increase visit time and healthcare costs. Another study, a recent clinical trial, tried to look at how removing race from a lung cancer decision tool would affect surgeons' decision. What they found was that when race was removed from the tool, surgeons started making different surgical decisions for lung cancer patients. And specifically, African American patients were less likely to be offered potentially curative lung cancer surgery, which could exacerbate racial inequities in the receipt of surgery, but also worsen long-term cancer outcome for these patients. So what should we do? Is there always a trade-off between wanting to keep race out of the tools and the accuracy of the tools? Can we do both, right? Can we create a model that keeps race out of the decision tool and not hurt people of color? And more importantly, is that even the right question to ask? So our research prompted us to step back to think about how these tools work. So these decision tools, whether they are powered by simple equations or by generative AI, they're really just tools. They are just mathematical formulas that are trying to pick up patterns from the data. Why do these formulas keep telling us that race is an important factor to consider? What if what is problematic is not the tool, but the data? So let's think through this. Many of these decision tools are informed by data from health records. So imagine your health records, right? What are health records? They are records of how people interact with the health system and not really records of your health. You only show up on your health record when you go into the clinic, right? And just because you did not go into the clinic, it doesn't mean that you were not sick. The health records really can't tell the difference between those who are healthy and those who are sick but just did not interact with the system. In our colorectal cancer study, the outcome that we were most interested in was whether or not cancer came back. In the medical field, they call this cancer recurrence. Cancer recurrence is one of those outcomes that is not recorded in any typical data sets, right? So we did what scientific communities often do, which is to make an educated guess about whether the cancer came back by looking at the type of health services patients use. Things like, did they get surgery? Did they get chemotherapy? Did they get an imaging procedure that would tell us that maybe their cancer has come back? So, for example, in the data set, we see that Miss Jackson's cancer, in the data set, how would you know that Miss Jackson's cancer came back, right? So let's say Miss Jackson didn't feel well. She came back to the clinic and reported symptoms, and then subsequently received surgery for her cancer recurrence. Or Mr. Chen noticed that Miss Jackson's biomarker count was off the chart when she came in for a regular checkup, and so Dr. Chen ordered more tests. And eventually, Miss Jackson got chemotherapy for her cancer recurrence. So in the data, we know that Miss Jackson's cancer came back because Miss Jackson interacted with the healthcare system and received healthcare services. So, but what's the problem with this approach, right? So let's think about it. What if another patient, Mr. Smith, he didn't feel well, but he didn't come back to the clinic? His cancer was too advanced when he did come back half a year later to the ER. And by that time, it was too late. he never got surgery. Or Dr. Chen noticed that Mr. Smith's biomarker count was off the chart when he came in for his regular checkup, but Mr. Smith did not have insurance, and so he never got chemotherapy for his cancer recurrence. So in the data, it would look like Mr. Smith's cancer never came back. So we also know that health service use vary across racial and ethnic group, right? So is it possible that the way that we are capturing cancer recurrence is more accurate among racial and ethnic minority groups? In other words, are there more patients like Mr. Smith in certain racial groups? So we went back to our sample of colorectal cancer patients and went and reviewed all the patients' charts and the doctor's notes to get at that true cancer recurrence status, that true health, right? And then compared that to what we derived from our clinical records, from our health records. And we confirmed what we had feared, which is that cancer recurrence, the outcome that we're basing all of our studies on, was significantly less accurate among racial and ethnic minority patients. And in fact, the 5-year recurrence for Hispanic patients was inflated by 11%. Okay, so this is getting more complicated, right? Our data contains an outcome that is less accurate for people of color. So what implication does that have on predictions from our decision tool? And of course, we can't stop there. So we did a series of computer simulations to try to disentangle this dilemma. We went in and artificially created an outcome that is only inaccurate among people of color, and then used that to build a decision tool and to see what the decision tool would say. It turns out that the more inaccurate your outcome is, the more your decision tool will tell you that race is an important decision factor. So why is this happening? The tool does not know that your outcome is inaccurate. It sees that the predictions are not matching up with the outcome for certain groups of people. So it starts to think that, well, maybe certain racial minority groups are just different. And so it assigns different levels of risk to these groups. So it keeps telling us that race is an important factor to consider. So what is this all telling us? It's telling us that the question of race versus no race as a decision factor cannot happen without assessing the bias that is already encoded in the data that is used to generate these tools. So what could we do now? We don't have all the pieces to know if race should be in a colorectal cancer decision tool, but now we know that the cancer recurrence outcome data is biased, and we can at the very least attempt to fix it. And once we're more confident about the data, we can then try to understand the long-term impacts of including race in decision tools for patients of color, which will hopefully give us more information about what the best approach is to prevent harm. So before I wrap up, I do want to leave you with a thought. I would like to invite you to think about what the data represents. Most data, whether it is our health record data or cancer registry data, or the data that is being used to train ChatGPT, are just raw data derived from people. They reflect the biases that are in our social structures and history, and the structural racism and inequities that exist in the world we live in. So next time you use a decision tool, whether it is to help you make a medical decision or to help you make a choice about the fastest route to come to town hall, I would invite you to take a moment to think about the world that the data represents that generated the logic behind the tools. Because maybe groups of researchers can figure out how to tweak the data or modify the math equations to generate decision tools that is fair one at a time. But to address that fundamental cause of the problem, to truly address the structural inequalities, we would need all of us. So thank you, everyone.